Alright, so continuing on, last time we left off right here, we finished up adrenal insufficiency and hyperaldosteronism, discussed stuff about how to memorize the changes in ions in both Addison and Kahn, or hypoaldosteronism versus hyperaldosteronism, and what scenarios you're supposed to see in metabolic acidosis and alkalosis and all of that stuff. Now we're looking at some neuroendocrine tumors, right? So neuroendocrine tumors, they're a heterogeneous group of neoplasms originating from neuroendocrine cells, which have traits similar to nerve cells and hormone-producing cells. So they kind of do both things. Most neoplasms occur in the GI system, like carcinoid or gastruloma, pancreas, such as insulinomas and gluconomas, and lungs, like small cell carcinoma, which we saw earlier. Small cell carcinomas can produce both your ADH as well as a CTH, right? Squamous cell carcinoma is the one that can make your PTH-related peptide. Also in the thyroid, your medullary carcinomas, which are going to be related to men's syndromes, and adrenals, which gives you pheochromocytomas. Alright, so this kind of is a quick summary of all your possible neuroendocrine tumors, which is what the pathology here is going to focus on, right? All of these guys. Whereas pathology and reproductive will focus on the other, whatever's left over. Characteristics differ depending on anatomical site, cells of origin, enterochromorphin cells, ECL-like cells, pancreatic beta cells, as well as secretory products like chromogranin A and neuron-specific enolase, serotonin, histamine, calcitonin. We're all going to see all of these things soon enough. Cells can also contain amine precursor uptake decarboxylase, which really isn't that big of a deal, but you can see that in the question, and we're going to see more about that right here. So the first thing we're going to be looking at is a neuroblastoma, right? So neuroblastoma is a tumor of the adrenal medulla. Neuroblastomas are almost exclusively pediatric tumors, age 4 or less, and the root blast in neuroblastoma tells us that these are immature cells, so they do not do a good job hypersecreting the normal hormones of the adrenal medulla, epinephrine and norepinephrine. The most common presentation is a huge abdominal mass that is irregular and capable of crossing the midline. In histology, the cells will look undifferentiated with big nuclei. These tumors can also be found anywhere up the sympathetic chain, such as near the neck or on the spinal cord. The most frustrating question will be regarding silly tumor markers or oncogenes, and you really need to print out the oncogenes. I think they were in, is it right here? No. Where do we see oncogenes? Pathology? Yeah, oncogenes from pathology. You need to print that out. You need to have that sheet in your hand at all times. There's a specific list of pages that you should have printed out, which are like lists and stuff like that, and that's one of them. You should definitely have printed out from pharmacology, the autonomic drug receptors. You should have printed out your oncogenes. Those are 2 pages so far that I've mentioned repeatedly should have printed out, and every time I think of more, I definitely tell you. So those are worth having, because you're going to see things like NMI's oncogenes showing up over and over. You should be able to go back and see, what was the whole story about NMI's. So neuroblastoma, most common tumor of the adrenal medulla, which is pretty much, the adrenal medulla we saw in pharmacology was pretty much its own its own nucleus in a sense, right? It's neuronic, and it secretes hormones directly into blood itself. Epinephrine, norepinephrine. But this is a child's tumor, right? Originates from neurocrest cells, occurs anywhere along the sympathetic chain. Most common presentation is abdominal distension and a firm, irregular mass that can cross the midline, compared to Wilms tumor, which occurs in the kidney, right? It's a renal cell tumor, and is smooth and unilateral. It doesn't cross the midline. Less likely to develop hypertension than with pheochromocytoma, which is actually a mature version of neuroblastoma. So there you release a lot of epinephrine, norepinephrine. This 4-year-old or younger child can present with opsoclonus myoclonus syndrome, which is known as dancing eyes, dancing feet, and it's just a really crazy eye and myoclonic thing that's happening. So their body and eyes are just moving around and shaking, very similar to a weird kind of seizure. A high HVA and VMA in urine. So these are your catecholamine metabolites when you break down epinephrine and norepinephrine. You'd also see Homer Wright rosettes if a histological image is given. So this picture of Homer Wright rosettes is actually really freaking nice, and you're probably going to get a picture that's a lot less obvious. Like this looks like a rose, it really has the petals in the center and all that stuff. So you want to look up more pictures of Homer Wright rosettes on Google. characteristic of neuroblastoma and medulloblastomas. Bombesin and neuron-specific amylase positive, associated with application of N-MYC oncogene, or NMYC, classified as an APUD tumor. So you're going to find more of the amine precursor uptake decarboxylase in that tumor as well. So over and over we saw this little thing talking about how it can cross the midline, right? So you should go ahead and find some x-rays. I'm going to show you some right now. So this here is one from Virginia.edu, med school, and they're showing you 4 different presentations, all of which are actually neuroblastomas, right? So you can see all 4 are CTs that are being taken at the level of the kidney. So you can see the kidney. You can see both kidneys here. This one not so much. Here you can kind of not see either kidney. It's really hard to find both of them. So this first one, you see the red arrow here, and you know this entire little big blob that's here. This is pretty much your neuroblastoma. It's coming from the kidney, from this patient's left kidney, because this is the right, this is the liver, from the patient's left kidney, and it's crossing over. You see how it's like a big thing sitting on top of your kidney, but the adrenal gland is not supposed to be that big, and it's growing, and it's going over to the other side. So that's what's happening in this picture. Here you can also see, but there's also calcification occurring, which is why this is so big and it's got a weird color to it, making it look very similar to the liver. This one, neuroblastoma encasing vessels, right? So your neuroblastoma is really just starting to cover your, at that point you're going to have your descending aorta and your inferior vena cava. And in this one, you have a liver that's really big and has really like dark spots in there, because that's liver metastasis. Right, so you can find a lot of pictures. Remember, to find CTs, x-rays, all of that stuff, all you have to do is go to any med school's page and you can just find lessons that they've uploaded. Right, so here we're seeing tumors of the neuroblastoma from your pediatric radiology section of Virginia.edu. Okay, so that's one. Then there's this other one right here. This is another image on the internet from researchgate.net showing you the same kind of thing. So again, you can see both kidneys. The left kidney looks like it's squished against the wall over there, and then you have this big thing that's happening. Right? And this is also crossing the midline. A large left-sided retroperitoneal tumor crossing the midline and encasing the aorta. Right? So very easy stuff, pretty straightforward. Wilms tumor, which is a renal thing, stays in the kidney, and kidneys are unilateral, so this doesn't really move over to the other side of the midline. And that's really all there is for neuroblastoma. Carcinoid syndrome is actually pretty high yield too. Very nice disease in the sense that it's easy in terms of tests, but there is stuff you can mess up. Now, we just finished cardiovascular, and we didn't really hear much about something happening to the tricuspid valve. But here, this is one case scenario that is related to the tricuspid valve. Let's check it out. So rare syndrome caused by carcinoid tumors like neuroendocrine cell tumors, no prominent rosettes again, right? Especially metastatic small bowel tumors which secrete high levels of serotonin. So here we're talking about a tumor coming from the small intestine and secreting serotonin. Not seen if the tumor is limited to the GI tract, because your serotonin undergoes first-pass metabolism in the liver. Results in recurrent diarrhea, cutaneous flushing, asthmatic wheezing, right-sided valvular heart disease, so tricuspid regurgitation or pulmonic stenosis, due to lung MAO-A enzymatic breakdown of 5-HT before left heart return. Right? Increased 5-HIAA, which is basically a breakdown product of 5-HT. Niacin deficiency, because we saw when we were in biochemistry and doing nutrition, we saw that you need niacin to make serotonin. So if you use up all your niacin and making all this excess serotonin, you run out of niacin. That leads to pellagra, and pellagra was the disease mainly studied in nutrition. Associated with neuroendocrine tumor markers like chromogranin A and synaptophysin, treatment is basically surgical resection, right? Especially only if it went to the liver, you do surgical resection. Somatostatin analogs like octreotide, because somatostatin will basically decrease serotonin release. And then they mentioned one medication, telotristat. This doesn't get mentioned ever again, telotristat. Telotristat is for symptom control. It is a tryptophan hydroxylase inhibitor. All right? So telotristat. So when you first studied this, if you already saw this medication here and you didn't look it up, and you just took it for granted as a medication for carcinoid syndrome, that was inactive studying, right? Active studying would be to go ahead and Google this thing, find out what it's about, and figure out where you would use it and how. So let's take a look at some of the notes I put here. First things first, I got another picture here, right? Another image of homocyte rosettes in a neuroblastoma under a microscope at 40x magnification. So again, you can see the rosettes very nicely, but you see completely different stain, completely different visual compared to this very nice image they gave you. So your neuroblastoma stuff can present in so many different ways, right? So many different ways to present. Prominent rosettes here too. So we're seeing 1, 2, 3 different forms of prominent rosettes. Main thing is you should be able to see some kind of rosette thing happening. So the tumor originates from neuroendocrine cells in the wall of the small intestine, and it secretes serotonin. The liver is really good at metabolizing serotonin, so a GI carcinoid tumor has no symptoms. However, that GI tumor will metastasize to the liver and dump serotonin into the hepatic venous system. The tumor will present now with carcinoid syndrome, with the classic triad of asthma, diarrhea, and cutaneous flushing. So look out for any patient presenting with those three symptoms. The niacin deficiency, which is vitamin B3, is due to the fact that serotonin is made from vitamin B3. So you're going to use it all up, and you're going to get pellagra, which presents with the 4 Ds: diarrhea, dermatitis, dementia, and death. Page 745 discusses bronchial carcinoid, because you can get bronchial carcinoid as well. That's going to be in respiratory, which would actually affect the left heart and cause mitral regurgitation. Typically, the right heart is affected due to carcinoid tumor in the terminal ileum. Alright, so we're going to see 2 different carcinoid issues, and carcinoid is high yield for step 1, so you got to be ready for that. Carcinoid tumors are most commonly arising in the small intestine and lung. Right, so bronchial carcinoid is the other issue. But if it's in the small intestine and then it metastasizes to the liver, in the liver you're going to make too much of that serotonin stuff, and it's all going to get sent to your right heart, right? Because you're going to drain into your right atrium, and then it's going to go into the right ventricle, and the lung. Right, the lung has MAO-A enzymatic breakdown of 5-HT before left heart return. So when you do all this breakdown, all of that stuff actually gets stuck in your right heart. The breakdown products. So the patient would have tricuspid regurgitation or pulmonic stenosis. Alright, and you got to remember things that are related to these guys. We already talked about tricuspid regurgitation and pulmonic stenosis in good depth when we were in cardiovascular physiology. And there was something about splitting. Right, splitting had to do with the pulmonic stenosis as well, in the sense that when you breathe in, the split was supposed to kind of become worse because you have more blood coming back to the right heart. But in this case scenario, it'll be really weird because the pulmonic valve doesn't even open. Right, so you got to go back and check what happens with pulmonic stenosis in terms of splitting. That is something you can have as an answer choice. Let me see. And then at the bottom here, I mentioned something about VHL. So VHL. Why do I talk about VHL here? Oh, okay. Yeah, I see. Okay, so we'll read it. So this is about VHL now. VHL is due to both mutations in both copies of VHL, which you find on chromosome 3 letters in VHL. It's associated with hemangioblastomas, angiomatosis, and pheochromocytoma, as well as renal cell carcinoma, pancreatic serous cyst adenoma, endolymphatic sac tumor, which we're going to see later on, bilateral papillary cyst adenomas of the epididymis in men, or broad ligament of uterus in women. So we're going to see some of that in reproductive later on. Angiomatosis occurs in about 30% of VHL patients, usually in the retina, leading to loss of vision. Hemangioblastomas occur in 40% of VHL patients' CNS. Neurofibromatosis 1 is caused by a mutation on chromosome 17. It is a developmental syndrome caused by germline mutations in neurofibromin, a group involved in RAS pathway. There will be musculoskeletal abnormalities affecting the skull, which can lead to congenital hydrocephalus. Note skin cafe au lait spots, freckling of the axillae, and dermal neurofibromas in NF1. See Lisch nodules in the iris and optic gliomas along optic nerves, leading to blindness as well. So this is just a little summary thing about VHL and NF1. I'm just trying to figure out why I put this here, but I think it's, because these are all the guys that are mentioned here, right? NF1, VHL, RET. We're going to see RET is related to MEN2A and 2B. So all of these are germline mutations that are related to pheochromocytoma, so I'm kind of summarizing that right here. But that's your next topic now, pheochromocytomas, right? So pheochromocytomas are the higher yield tumor compared to neuroblastoma. It's also an adrenal medulla tumor, but these are well-differentiated cells that are very good at secreting catecholamines. Often they are secreted in short episodes or bursts, so it may lead to episodes of sympathetic hyperactivity such as palpitations, perspiration, pallor, and super hypertension, like 200 over 100, which can also cause severe headaches. Not only does the beta adrenergic activity push the heart to maximize CO, cardiac output, but the alpha adrenergic activity causes systemic vasoconstriction that cranks the blood pressure up by Ohm's law. So blood pressure is equal to cardiac output times systemic venous return. You will see metanephrines, HVA and MVA, as well as catecholamines, and the HVA and MVA are sensitive and specific for Pheos, unlike neuroblastomas. See, the thing with neuroblastomas was it was in kids, so even the tumor itself is childish in the sense that it doesn't really do much in terms of secreting a ton of epinephrine and norepinephrine, so you don't get many metabolites either. You'll see some, but not that much. It'll be more than normal. Here, you're going to see a lot of epinephrine and norepinephrine because this is an adult now, and you're also going to see a lot of breakdown products. So what are symptoms that you're going to see from pheochromocytomas? So they call it as the 5 Ps, but there's definitely much more than 5 Ps. I used to have it written here. Let me see. Let me find that real quick, because there's polycythemia and stuff too. Let's see. We go to pheochromocytoma. Yeah, right here. Okay. Polycythemia and periodic. Let me bring that over. Alright, so all the P's. Now, I wish this guy could have waited a little longer before starting, but he only starts at freaking noon. So obnoxious, man. He's not even building anything. He's really just a schizophrenic in a sense. He's just cutting down random stuff. Right now, he's cutting bicycles up for no reason whatsoever. It's really, really lame. Alright, anyway. So, what are symptoms with pheochromocytomas? Most tumors secrete epinephrine, norepinephrine, and dopamine, which can cause episodic hypertension. Right? Epinephrine, norepinephrine, dopamine, these are all the guys that are going to go to your alpha and beta receptors and turn them on. So you're going to have sympathetic hyperactivity. May also secrete EPO, leading to polycythemia. Symptoms occur in spells, right? Relapse and remit. So you're going to see a patient who's going to explain to you that they keep getting these like pains and headaches and stuff, and then it goes away. Or it doesn't happen for a couple of days, then it happens again. If the patient is keeping a blood pressure log, then you'll see there are days where their blood pressure is very high, and then there are days again where their blood pressure is purely normal. Or not as high, a lot lower. Right, so those are things you want to watch out for. So that's why I added more P's here, right? So normally you're going to see high blood pressure, pain from headaches, perspiration because they sweat like crazy. Sympathetic activity is like, fight or flight, and when you do either of those things, you're going to sweat. You're going to have a high heart rate, and you're going to have pallor, right, because you're just like tired and scared or whatever. Polycythemia and periodic are the other P's that you want to keep in mind too. The rule of tens is kind of unnecessary. I really don't find the benefit of it because it doesn't really tell you what you can actually use, right? 10% are malignant. Okay, sure. So most pheochromocytomas are not malignant, right? These are all 10%, which means 10% is a pretty big percentage, but it doesn't really, it's a significantly smaller percentage than the 90%. So it's more of a rule of 90% if anything, right? So most of them are not malignant. Most of them are not bilateral. Most of them will just be purely adrenal, right? But 10% they're telling you that it could go to bladder wall or the organ of Zollinger-Ellison. Really not that big of a deal. Only 10% calcify, so most of them don't calcify. 10% can occur in kids, but we know most occurs in adults. So the rule of tens is really like, I don't see the point of it, to be honest, because we can see what happens mostly. That's what we should be really worried about, not what happens rarely, right? 10% of the time. We're more so into what's happening 90% of the time. Findings are what we already talked about, very high amounts of epinephrine and norepinephrine, as well as their breakdown products, HVA and VMA. So now treatment is also really easy to remember. Just remember it goes in ABCD order. Right? So you have to give an alpha blocker first to stop the alpha-1 vasoconstriction. Stop the alpha-1 vasoconstriction, so you get some vasodilation there. And then you give a beta blocker to stop the beta-2 vasodilation and get some vasoconstriction there, so that everything becomes normal. I think I have a... No, I don't have... there used to be a picture. Yeah, this one. So you can see alpha 1 is causing this to occur, and beta 2 is causing this to occur in the patient itself, right? If you give an alpha 1 blocker, you stop this, so that becomes normal, and then you give the beta 2 blocker and you stop this, and that also becomes normal, thereby making everything normal. Alright, so that's kind of what you want to watch out for with treatment. If you do end up giving the beta blocker first, if you give the beta blocker first, you're going to cause vasoconstriction here too. Then you'll have vasoconstriction everywhere, and that's going to be very bad, right? Because then that hypertension can kill the patient. So alpha blocker and then beta blocker. So phenoxybenzamine is the alpha blocker you could choose, and then almost any beta blocker works as long as it blocks beta 2. Okay, that's the one you want to target. And that's really all there is for pheochromocytomas. No big deal. Very easy to answer those questions. Insulinoma, glucagonoma, and somatostatinoma are all things that might look very easy when you read it, but they can get very confusing in questions. So in insulinoma, obviously, it's a tumor of the pancreatic beta cell, and you're making too much insulin. So if you're making too much insulin, you're going to have hypoglycemia. But keep in mind that too much insulin also means you're going to gain weight, right? Because insulin is very anabolic. So don't think of insulinoma as a patient who's supposed to be thick, skinny, and weak, right? They're going to be weak because they don't have any sugar, but they're huge as well. Right? So you're going to see the Whipple triad: low blood glucose, hypoglycemia, so syncope, diplopia, and resolution of symptoms after giving glucose. That's what the Whipple triad is about. They love throwing that into questions, right? Maybe they'll be like, and then you gave this patient a glass of water with a bunch of sugar in it or some kind of juice, and they felt better. Symptoms went away, right? Because you gave all that insulin some sugar for it to work with. Symptomatic patients have low blood glucose and high C-peptide levels. That's another thing you want to watch out for. Remember we talked about how C-peptide is only high if you're making a lot of your own insulin, but if you're injecting insulin into yourself, your C-peptide level will be non-existent. There's no C-peptide in the insulin you inject into yourself. So when you see high C-peptide levels and this patient is presenting with hypoglycemia and high C-peptide level means this patient is making too much insulin themselves. 10% of cases are also associated with MEN1 syndrome. And when we get to MEN1 syndrome, we're going to see MEN1 has many other weird cancers associated with it. Insulinoma is one of them. I think the other one is a VIPoma associated with, MEN1, associated with MEN1 syndrome, right? So VIPoma and insulinoma are both things you're going to see in MEN1 patients. MEN1 questions are pretty difficult, so we'll take a look at all the MEN diseases. You definitely need to know the MEN syndromes because those are very high yield. So insulinoma will present with excess insulin, but hypoglycemia isn't as rigidly defined as hyperglycemia. Symptoms occur in two phases. First, the body has a minor panic attack at 50 milligrams per deciliter of glucose, right? So glucose went down from about 120 to 50, and kicks up all the catabolic hormones like glucagon, cortisol, growth hormone, and most importantly, epinephrine is the one that will cause symptoms. Remember we saw in biochemistry, when you have low sugar, all of these guys kick into action. All right, so let's take a quick revisit at some of that stuff. So really quick revisit to managing hypoglycemia. So right here, right, fasting and starvation, metabolic fuel use, and we saw this, right, physiologic defenses against hypoglycemia. You're going to have low insulin because you don't have any sugar. In that case scenario, in an insulinoma, you're going to have high insulin, which is causing the hypoglycemia. So you're going to make more glucagon, more epinephrine, more cortisol, more growth hormone, all of them. Cortisol is the only one, though, according to this question. Cortisol is the only one that uses an intracellular receptor because it is a adrenal cortex derivative, right? And it is made out of cholesterol. So it's a cholesterol derivative, so it's going to go there, right? It's intracellular. The others are going to not use intracellular growth hormone, glucagon. These all use different things. But this is how you deal with hypoglycemia, and hypoglycemia in insulinoma patients is the only case scenario where you have the same things but high insulin as well. And so you make all of that, the brain starts running out of energy, and that leads to coma. So you can see how things are starting to get really bad. High glucose is this way, hypoglycemia is going this way. So when your glucose reaches about 50, you get sympathetic hyperarousal, you start seeing all the symptoms of sympathetic activity, and then you have decreased CNS function if you never fixed it. And sympathetic hyperarousal is a symptom of hypoglycemia, right? This is why we always say don't give beta blockers to patients who might have hypoglycemia sometimes. If you give beta blockers to a diabetic patient, you'll never see sympathetic hyperarousal, and that's going to mask the signs of diabetes, right? So definitely something you want to watch out for. Then you have glucagonoma, which does very unpredictable things actually. Right, so glucagonoma is an alpha cell tumor. You're just going to have too much glucagon, so you're just going to have too much sugar. But it ends up doing these weird 5Ds. You end up having dermatitis, specifically necrolytic migratory erythema. You should Google that, find some pictures. Necrolytic migratory erythema can be given to you as like a picture of a patient, and they'll ask you what's wrong. They're obviously going to have diabetes because they're going to have too much sugar in their body. They can get DVTs, deep vein thrombosis. They're going to have declining weight, and they're going to have depression. Right? So such a weird list of things that you probably could not have predicted would occur to a patient just because they're releasing too much glucagon. Treatment of this is any somatostatin analog like octreotide to stop glucagon secretion. Right? So glucagonoma will present with excess glucagon-inducing hyperglycemia, hyperlipidemia, and more, which will present with similar symptoms to diabetes mellitus. However, main symptom is dermatitis, which has painful erythematous lesions affecting the face, groin, and extremities. Lesions become necrotic, then slow off, or form indurated plaques with brown bronze color, and that's what you should see in some of the pictures you look up for glucagonoma-induced necrolytic migratory erythema. Last one of these guys is somatostatinoma, which is a tumor of the delta cells. So now you're going to make too much somatostatin, which is static. It stops things, right? So this is going to stop glucagonoma and insulin. It's going to stop glucagon and insulin secretion. So you have decreased secretion of everything, basically. Secretin, CCK, glucagon, insulin, gastrin, GIP, all the things you're going to see when you get to gastrointestinal physiology. May present with diabetes, glucose intolerance, steatorrhea, right, because you don't have any CCK, so you're not releasing bile. Gallstones, again, because you don't have any CCK, so you're not releasing bile. Achlorhydria, right, because you have GIP inhibition. And treatment is just surgical resection for the most part. Even somatostatin analogs don't really help because that's kind of silly, right? You're already releasing a lot of somatostatin. Why would you give more? But surgical resection of the pancreas is generally going to just fix this up, and then the patient has to be on insulin and sugar control for the rest of their life. And that's generally all there is. So that takes care of your pancreatic tumors. And then we have Zollinger-Ellison syndrome. Zollinger-Ellison syndrome. And then we'll look at these practice questions that I have over here. So Zollinger-Ellison syndrome is a GIT issue, but it's also endocrine. So it's a gastrin-secreting tumor or a gastrinoma of the pancreas or duodenum. Acid hypersecretion causes recurrent ulcers in the duodenum and the jejunum. Right? So duodenum and jejunum are going to have too much ulcers in there because there's too much acid. Remember that all the acid that was being made in the stomach was going to get neutralized before entering the duodenum, right? Because you don't want any acid in there. Here you have a gastric-secreting tumor, so there's too much gastrin, so acid actually makes it to the duodenum and even jejunum. So now you're going to have pain with abdominal pain, peptic ulcer disease, distal ulcers, diarrhea, positive secretin stimulation test. This is a very important one. Secretin normally does something else, right? But here we're going to see secretin, gastrin levels remain elevated even after administration of secretin, which normally inhibits gastrin release. And we're going to see more of that when we get to GIT physiology, right? So in any normal adult, when you give them secretin or they release their own secretin, gastrin secretion decreases. But in ZES, in Zollinger-Ellison, for some reason, when you give them secretin, they make more gastrin, or gastrin just stays as high as it was. And Zollinger-Ellison syndrome is another thing you can see in men 1. So the fact that you can see insulinoma, VIPoma, and Zollinger-Ellison syndrome in men 1 makes men 1 a little difficult of a topic because you can get a patient who has Zollinger-Ellison syndrome symptoms, but the answer is actually men 1 because they might have mentioned one more thing about the patient, So you really got to make sure you're checking everything. So now let's take a look at all these questions we have. First one here, this is from USMLE. This one just says, what are the first symptoms of hypoglycemia in a patient with insulinoma who also takes metoprolol for blood pressure? So remember we just spoke about how if you take beta blockers, you're going to get rid of the sympathetic hyperarousal, which was actually the first symptoms you're supposed to see. So now the first symptom you're actually going to start seeing eventually are going to be CNS symptoms. lethargy, altered mental status, eventually leading to coma. Beta blockers decrease sympathetic hyperarousal associated with mild hypoglycemia. Right? So first symptoms of hypoglycemia are usually of sympathetic hyperarousal, but beta blockers mask those effects. So no panic attack or palpitation will occur. It goes straight to the CNS effects. Alright, now we have some AMBOSS stuff, so let's kick ass. 45-year-old woman comes to the physician because of fatigue, irregular menses, and recurrent respiratory infections for the past 6 months. Her blood pressure is 151/82. Physical exam shows a round face, thinning of the skin, and multiple bruises on her arms. Further studies confirm the diagnosis of an ACTH-secreting pituitary adenoma. This patient is at greatest risk for which of the following? And the answer was a pathological fracture. Right? 54% of people chose that. 32% chose bitemporal hemianopsia. But you got to keep in mind, bitemporal hemianopsia occurs with any pituitary adenoma. Most likely, though, it occurs with the prolactinoma. ACTH secreting pituitary adenomas are actually under feedback inhibition from the cortisol that you're making because of the ACTH. So it's not going to get that big. An ACTH secreting pituitary adenoma only becomes symptomatic in terms of vision in Nelson syndrome, where you took out the adrenal glands and now you don't have that pituitary feedback, right? So this patient presents with typical findings of hypercortisolism, right, and is due to her Cushing disease. Cushing disease is associated with pathologic fractures because that's kind of what cortisol does. It decreases bone formation, and she's 45. Excess cortisol inhibits calcitriol and osteoblast maturation while simultaneously increasing production of rank ligand. Rank ligand, remember, was the guy that goes to rank receptors on osteoclasts and turns them on. So that's pretty bad right there. And then you end up breaking bone. Other features of Cushing disease include cataracts, peptic ulcer disease, dyslipidemia, muscle atrophy weakness, acne, hirsutism, and psychiatric conditions such as generalized anxiety disorder, major depression, and psychosis. Bitemporal hemianopsia is a complication of pituitary macroadenomas, big adenomas, such as prolactinoma, gonadotropinomas, somatotropinomas, or thyrotropinomas. Bitemporal hemianopsia is caused by compression of the optic nerve at the level of the optic chiasm. While the patient's hypercortisolism is due to pituitary adenoma, she's unlikely to develop bitemporal hemianopsia as Cushing disease is most commonly caused by microadenomas rather than macro. Right? So ACTH secretion, you don't need that much ACTH secretion to get hypercortisolism, and that pituitary adenoma is very tiny, so it doesn't actually necessarily have to cause bitemporal hemianopsia. It can happen, but it doesn't answer the question, which is greatest risk. So the greatest risk is for bone fractures or any other symptom that can be due to cortisol. Then we have this question. 44-year-old woman comes to the physician because of a 3-week history of frequent episodes of headache, diaphoresis, palpitation, and anxiety. Her blood pressure is 148/85. Physical exam shows no abnormalities. Serum studies and a 24-hour urine collection show an increased concentration of metanephrines. A CT scan of the abdomen shows a 3-centimeter mass in the left adrenal gland. The mass is derived from cells that are physiologically activated by which of the following molecules? So obviously they're talking about the adrenal medulla, and it's a 44-year-old patient. We're thinking of like Pheochromocytoma, right? And they want to know what molecule activates those guys, right? The mass is derived from cells that are physically activated by which of the following cells? And the answer was acetylcholine. The image below, this one was given with the explanation. An adrenal tumor on CT scan, along with increased catecholamine metabolites and paroxysmal why is this stuck together? Hyperadrenergic symptoms like headache, diaphoresis, and anxiety is suggestive of diagnosis of pheochromocytoma, a catecholamine secreting tumor that arises from chromaffin cells of the adrenal medulla. Pheochromocytomas arise from the adrenal medulla in 90% of affected patients. The adrenal medulla is a modified sympathetic ganglion that is innervated by sympathetic preganglionic neurons. The preganglionic neurons secrete excitatory acetylcholine to trigger the activation of postganglionic neuron, which in this case of adrenal medulla will later secrete epinephrine and norepinephrine. And we saw that. We've already seen that. This is why you do all the principles first. So when we go back here, right, again, this is one of the pages you're supposed to have printed out as well because of this stuff. So you can see everything is activated by acetylcholine, literally everything. The preganglionic neurons all release acetylcholine. Acetylcholine comes to here, does all the sympathetic chain stuff. Acetylcholine also comes to your adrenal medulla and activates it. It then releases norepinephrine and epinephrine. So that question was like a question 100% of people should have gotten right, at least 90%, right? But it didn't actually happen. I didn't write down the percentage, but not many people got it right. A lot of people actually fell for picking epinephrine, norepinephrine, stuff like that. That's wrong, right? They're asking you what turns on adrenal medulla to do its activity, and it's obviously acetylcholine. Everything gets turned on by acetylcholine. And then what it does depends on whether it's part of the parasympathetic or sympathetic chain. So this here is an explanation of the picture. Feel free to pause the video whenever you want to take a look at that. Then we have this question right here, 47-year-old. So 47-year-old woman comes to the physician for a 2-month history of fatigue, intermittent left-sided flank pain, and diffuse extremity pain. She was treated for a prolactinoma 5 years ago and has had recurrent antral and duodenal peptic ulcers despite medical therapy. Her only medication is omeprazole. Physical exam shows a moderately distended abdomen that is diffusely tender to palpation. There is mild left-sided costovertebral angle tenderness. Serum studies show a calcium of 12, phosphorus of 2, and PTH level of 226. So PTH is supposed to be 15 to 65, so she has very high levels of PTH. An ultrasound of the abdomen shows multiple kidney stones in the left ureteropelvic junction, which is why she has the flank pain. That's usually what causes flank pain. This patient is most likely to have which of the following protein abnormalities? And almost no one got this right, but the answer was altered menin protein. And this is actually a question of MEN1, right? You see, she had things that were similar to different diseases we just looked at. So let's read the explanation. You'll see what I'm talking about. This patient has evidence of hyperparathyroidism, right? So that's your parathyroid gland, and a history of recurrent ulcers, which suggests Zollinger-Ellison syndrome, which you do see in MEN1. The constellation of parathyroid, pituitary, which she had a history of, prolactinoma. So she had pituitary, parathyroid, and pancreatic disease. That's MEN1. 3 Ps, MEN1, right? Altered menin protein function resulting from a mutation in the MEN1 gene is seen in multiple endocrine neoplasia type 1. MEN1 is characterized by the 3 Ps pituitary tumor, which was her prolactinoma, parathyroid gland tumor, which was her primary hyperparathyroidism, and any pancreatic tumor like a gastrinoma, insulinoma, right? And she has the gastrinoma. MEN1 is also associated with angiofibromas and meningiomas, right? So 2 other things that you can get tested on. So the thing here is, right, thank God step 1 is a multiple choice test. So when you look at your choices and you see menin protein or MEN1 as a possible answer choice, go back to the question stem and cancel out the answer choice. If you can't cancel it out, it's MEN1, right? And that's kind of how you want to really deal with MEN1. Then you have the rest of these. So 38-year-old. 38-year-old woman comes to the physician because of a 4-month history of crampy abdominal pain, recurrent watery diarrhea, and a 5.5-pound weight loss. Her husband has noticed that after meals her face and neck sometimes become red, and she develops shortness of breath and starts wheezing. Examination shows a grade 3 out of 6 systolic murmur, heard best at the left lower sternal border. So now, left lower sternal border, remember that one was your tricuspid valve kind of area, right? APTM. The abdomen is soft and there is mild tenderness to palpation with no guarding or rebound. So she doesn't have anything to do with her, what do you call that? Guarding or rebound. The word is skipping my mind. I can't remember. But the thing that you have in the corner, appendicitis, there you go, yeah. Alright, so she doesn't have appendicitis because that's usually where you get guarding or rebound. The other guarding or rebound you can get is with the gallbladder issues. If you do palpation here, they should really, be like, oh my god, that hurts or something. And she doesn't have any of that. Without treatment, this patient is at greatest risk of developing which of the following conditions? And the answer was pigmented dermatitis, which again, very few people picked. So let's take a look at what happened here. So, watery diarrhea, crampy abdominal pain, and episodic cutaneous flushing triggered by eating or by emotional events, asthma-like attacks, and a murmur indicative of tricuspid regurgitation are highly suggestive of Carcinoid Syndrome. As you can see how weirdly the presentation of Carcinoid Syndrome kind of looks, right? Carcinoid Syndrome. The neuroendocrine tumor is highly metabolically active and secretes excess amounts of serotonin. Dermatitis is a characteristic feature of pellagra, or niacin deficiency. Other key findings include dementia and diarrhea, the 3Ds, and of course death also, because of niacin deficiency, because you use all your niacin up to make all this serotonin. And carcinoid. Dermatitis in patients with pellagra is characterized by a symmetrical, pigmented, scaly thickening of the skin in sun-exposed areas, such as the limbs, around the neck, which is known as the castle necklace, and you get to see that in biochemistry nutrition. The increased metabolism of serotonin in carcinoid tumor depletes the amount of tryptophan precursors available for other organic compounds, including niacin. A lack of niacin leads to decreased production of the coenzymes NAD+ and NADP+, which are essential in redox reactions throughout the cellular metabolism. Right? So now we're kind of getting that connection with biochemistry, where we see a lot of NAD+ and NADP+, and you really need to know what they're for. Diagnosis is confirmed via a 24-hour urine testing for 5-HIIA, the end product of serotonin metabolism. All right. So pigmented dermatitis. So this was like a third-degree level kind of question in this case, where you had to first figure out she has carcinoid, second figure out that carcinoid leads to pellagra because you don't have any niacin, you can't make niacin anymore. Tryptophan all got used up, and without niacin, the pellagra symptoms are dermatitis, dementia, and diarrhea. So dermatitis was the answer, right? Third-degree question over here. And step 1 does ask a lot of questions like that, where when you look at the answer choices, none of them looks like it's related to what's happening to the patient because it's not a first-degree question. A first-degree question would be like, oh, this patient has A1C of 8%. What's her disease? It's just diabetes, and that's too easy. Next, a 44-year-old woman comes to the physician because of a 6-month history of fatigue, constipation, and 15-pound weight gain. Menses occur irregularly, 40 to 50-day intervals. Her pulse is 51 per minute, and blood pressure is 145. Pulse is low, right? It's supposed to be more than 60. Blood pressure is 145/86, so it's a little high. Examination shows conjunctival pallor and cool, dry skin. There's mild, non-pitting periorbital edema. Serum TSH is 8.1. Treatment with the appropriate pharmacotherapy is begun. After several weeks of therapy with this drug, which of the following hormonal changes is expected? And this was the weirdest question I had seen in a long time, but the answer was increased reverse T3. And you know what reverse T3 is? It's basically T4, right? Because T4 is supposed to become T3, so if you reverse the T3 backwards, it makes T4. And that's kind of what that was about. I had never heard of reverse T3. But basically all her symptoms of weight gain, fatigue, it looks like she has hyperthyroidism, and then when she has periorbital edema as well, that's Graves' disease, right? So the patient's signs and symptoms of fatigue, constipation, weight gain, menstrual irregularities, bradycardia, hypertension, dry skin, periorbital edema are also... Sorry, what am I saying? My bad. This is hypothyroidism, right? Because weight gain. Hyperthyroidism makes you lose weight. All this excess metabolic activity. She's got weight gain. That's hypothyroidism, where you need to take levothyroxine. Excuse me there. Starting to get real hungry. I don't know if you can hear me. My stomach's kind of growling. So that was hypothyroidism, right? Because weight gain occurs when you don't have any levothyroxine. When you have too much thyroxine, that's hyperthyroidism. And things like Graves' disease, you're also going to have the periorbital stuff, but it's also the eyes are sticking out. And all of that occurs because in Graves' disease, it's a whole different scenario. But in Graves' disease, you're going to see you actually have antibodies that attack things and make them bigger. That's a very weird thing that happens in Graves' disease. But this patient, with all her symptoms, is like yelling out at you that she has hypothyroidism. In fact, they kind of gave you the diagnosis when they told you that her TSH is 8, which is very high. Right? TSH is high because her body's trying to make her make more thyroid hormone. So now they gave her some medication, and you start seeing more increased reverse T3. Why? Well, let's take a look. So obviously she has hypothyroidism, hypo. The elevated serum TSH indicates that he has. She has primary hypothyroidism, for which the treatment is hormone replacement with levothyroxine. Levothyroxine is a synthetic form of T4, which is converted to reverse T3, biologically inactive, and then T3, which is biologically active. So the easier answer would have been you're going to see more T3, but they didn't have that. and all the other answer choices actually looked really weird. And when you get something like this on step 1, what you're supposed to do is just pick the thing that looks most logical. So I actually ended up telling the student that I was working with to pick increased reverse T3, because we were looking for increased T3, and of course something about thyroxine is going to increase now. That's what you're helping her with, right? You initiated therapy. So all the other answer choices were like reduced T4, reduced T3, and blah blah, stuff like that, and those were obviously wrong. They didn't have an answer choice that said increased T4 or increased T3. They just had increased reverse T3, and that's really all there was to pick. Right? So since an increase of reactants leads to an increase in products, reverse T3 would be expected to increase after several weeks of levothyroxine therapy. T3 and T4 negatively regulate the secretion of TRH from the hypothalamus and of TSH from the anterior pituitary. So reverse T3 is mentioned in this question, and it's a very new concept I've never heard of before for hypothyroidism, so I made sure I put that question in here. Next up, 36-year-old woman is brought to the emergency department because of lightheadedness, weakness, and abdominal pain for 6 hours. Over the past 3 days, she has also had severe nausea, vomiting, and watery diarrhea. She was diagnosed with pulmonary sarcoidosis. Alright, so we haven't covered sarcoidosis yet. 2 years ago. Current medications include prednisone, which is something you get for sarcoidosis. Her temperature is 102, so she has fever. Pulse is 112, which is very high, and blood pressure is 85/50, which is low. Physical exam shows a round face with prominent preauricular fat pads. Her fingerstick blood glucose is 48, which is also low. Further evaluation is most likely to show which of the following lab changes, and the answer was decreased CRH. So clearly, something about this question is spelling out excess cortisol, right? And she's actually been taking exogenous corticosteroids, which is prednisone. Who knows how long she's been taking it for, but if you take prednisone, you basically eat cortisol, so your adrenal glands are not going to make any cortisol, so you end up getting bilateral adrenal atrophy, and the reason they're not making any cortisol is because you're not releasing CRH or ACTH, and that's why this was the answer. So hypotension, hypoglycemia, abdominal pain, after using glucocorticoids for a long time, is going to lead to acute adrenal insufficiency. Adrenal crisis is a severe acute glucocorticoid deficiency that is usually precipitated by a trigger, such as infection, dehydration, trauma, or surgery, all of which are cases of stress, right? And if you have stress, your adrenal gland better be there to put up with it. If it's not, you're going to have a lot of problems. See, mine is HD output too. Okay. So because this patient has been taking excess or exogenous glucocorticoids, she just has Cushing Syndrome, not Cushing disease. It's not related to her pituitary gland. Cushing Syndrome, so her ACTH and CRH are going to be low. And that's all this question was really about. Very easy, very straightforward. Don't get too confused and don't think too hard. All right. Last one, 58-year-old woman brought to the emergency department 30 minutes after developing acute confusion, severe headache, and vomiting. Okay. Physical exam shows left-sided numbness. A CT scan of her head shows a large intraparenchymal hemorrhage. So it kind of sounds like a neurology question, right? Despite appropriate treatment, the patient dies. Autopsy shows multiple small aneurysms of the lenticulostriate arteries of the brain and bilateral hyperplasia of the adrenal glands, limited to the zona glomerulosa. The patient's adrenal condition was most likely associated with what symptoms? So when you get to neurology, you're going to see that hypertension can actually cause lenticulostriate arteries to have hemorrhage, and you can die, right? You can also get a Barry aneurysm, stuff like that. And since they tell you that she had hyperplasia of the zona glomerulosa, that's the G that makes aldosterone. So she has too much aldosterone, and all of that aldosterone is basically going to cause her to have hyperaldosteronism, where she's going to have hypertension and die because of that. So what symptom, right? The patient's adrenal condition is most likely associated with what symptoms, though? So 33% chose muscle weakness, while 42% chose peripheral edema, right? But this is primary hyperaldosteronism. Primary hyperaldosteronism, remember we just spoke about will not have high sodium levels. It's going to have normal sodium levels because of something known as the aldosterone escape mechanism, where ANP causes natriuresis, so you pee out the extra sodium. So muscle weakness was the correct answer. She had a Charcot-Bouchard aneurysm, microaneurysms of the lenticular striate artery due to hypertension because of all her hyperaldosteronism. The findings of bilateral zonal glomerulosa hyperplasia indicate primary hyperaldosteronism, aka Cushing syndrome. Muscle weakness is a sign of hypokalemia, which occurs in Cushing syndrome. When it occurs in hyperaldosteronism, as we discussed, you're going to keep sodium, so you're going to lose all the potassium. Hypokalemia causes muscle weakness, and it can develop in patients with primary hyperaldosteronism due to stimulation of potassium excretion in the urine caused by excess aldosterone. Other symptoms of hypokalemia include fatigue, headaches, polyuria, polydipsia, palpitation, and constipation, and you need to know all of that, right? Primary hyperaldosteronism also causes metabolic alkalosis due to increased H+ excretion in the urine. Aldosterone causes retention of sodium in water, which leads to volume expansion. However, now we get to see the aldosterone escape mechanism. This in turn leads to increased ANP secretion in atrial myocytes, resulting in increased diuresis and sodium excretion, or natriuresis. This process is known as the aldosterone escape mechanism and prevents peripheral edema and frank hypernatremia from developing in patients with Cushing. So 42% of people got the question wrong, even though they had the right idea. She's making too much aldosterone. That's because you have to remember that in primary aldosteronism, sodium is normal. It's not going to be high as you would expect because ANP fixes it. ANP normalizes it. All right. So that takes care of all the practice questions from there. The last thing I'll just look at, just because it's still related to the things we were talking about, is the Pheochromocytoma. This is a rare neuroendocrine tumor. The last one we're talking about right now. It secretes VIP, which is vasoactive intestinal peptide. It also most commonly arises from the pancreas, so it's also pancreatic, which means it's also associated with MEN1. And primary symptoms of Pheochromocytoma are diarrhea that's very secretory. So WDHA, right? Watery diarrhea, hypokalemia, of which we just spoke about symptoms, and achlorhydria, which means you're not going to be able to make HCl, okay? So Pheochromocytoma patient will present with metabolic acidosis. Initially, fluids and electrolytes must be replaced, and bicarbonate must be given to replace the fecal loss and avoid acidosis. Large doses of octreotide may be needed to control the diarrhea. Give supplemental pancreatic enzymes, since octreotide suppresses pancreatic enzyme secretion. Everything. You don't make any of those pancreatic enzymes. Usually arises sporadically and is located at the pancreatic tail. VIP reduces gastrin secretion, which can lead to iron and B12 malabsorption as well, resulting in anemia. VIP also tells the liver to do more glycogenolysis. Alright, so Pheochromocytoma will cause more glycogenolysis, which is also going to be problematic. All in all, though, a Pheochromocytoma is also related to MEN1, and you want to make sure you remember that. Alright, so a lot of things related to Pheochromocytoma as well. Watery diarrhea, no blood, and that's it. So that takes care of all of our neuroendocrine tumors, as well as Pheochromocytoma and Neuroblastoma and Carcinoid Syndrome. Alright, so really getting close to mastering everything we're going to see in MEN1. The next video, I'll go into hypo versus hyperthyroidism, right? And we're going to take a look at all the histological findings and stuff like that. Really get an understanding for how you're supposed to be able to differentiate the two things. We'll look at thyroid cancer. So the next video is going to be all about shit that goes wrong with the thyroid, and we'll do a bunch of practice questions regarding that. Alright, so I'll catch you guys in the next video when we do that stuff.